Hello, good evening, and welcome to your favorite health show, Ask Dr. Sawh. As you know, the show comes to you every Tuesday night at 8 p.m., where you have an opportunity, and this is a platform for you to call in, send your questions about any health topic or illnesses or ailment, and Dr. Sawh, who is here in the studio every night, every Tuesday night, to answer your questions. So this show is possible because of Dr. Sawh. So, Dr. Sawh, welcome again to tonight's show.
Thank you.
Yeah, a little rainy today. A change of weather.
Yeah. I mean, good for I suppose the farmers are happy.
Exactly. Yes, I saw somebody put on Facebook, because of the heat that happened this morning at 5:30 from the president, little rain was needed to cool things down.
Yeah.
But Dr. Sawh, tonight's topic is menopause, and because of some of the questions we've been getting via Facebook and some of the feedback, and it's possibly one of those frequently asked questions about menopause. And I myself have got quite a number of questions to ask you, because I mean, when I was telling a couple of people who follow us about what, the topic for tonight, and because they're a little shy to call in or to say, so some of them they have given me their questions to ask you. So those are some questions I'm going to be posing to you tonight. This show is really possible because of you, the viewers, though, and we want to thank you so much for joining us here every Tuesday night at 8 o'clock. And it's such a wonderful thing to have so many questions coming through, to have so many calls coming. Well, we don't get as much calls, but we appreciate that you're sending your questions via Facebook and WhatsApp. So tonight, again, you're going to have that opportunity to send in your questions when we give you the go-ahead. First, Dr. Sawh is going to talk to us a little bit about menopause. I'm going to start off tonight, Dr. Sawh, by asking you, look, from what I've learned is that menopause is really a natural process, an aging process where the ovaries, it's time. What really is menopause?
I mean, you're right. It is a natural process, but there are times when it could be due to other illnesses. However, by large, the majority of causes are natural menopause that you go through as you age. So I will just start by giving a definition. What is menopause?
Yes.
So menopause is cessation of menstruation. As simple as that.
Yes.
Menstruation pause. Simple.
Oh, menopause.
But is permanent cessation.
Right.
And as a result of ovarian inactivity, so loss of ovarian follicular activity. So we know our ovaries produce, the ovaries produce hormones, and you have it stimulates other hormones in the body, and then you have that balance of hormone, and then at certain time there are different changes in the degree, the levels of hormone, and then you have shedding of the lining of the womb, and that's your period. So when those hormones cease to function at that level, you have cessation of your period, and that is called menopause. So, so that is a simple definition. The thing is, I know menopause is a topic. I choose this topic because I think it is not talked about a lot. There are some taboos surrounding menopause, and all these things, different cultures approach it differently. More and more now, health conditions are being discussed openly, and we encourage patients to talk a lot about them. And and I think with the internet and social media and all of that, people are becoming more and more aware. So I really want to do this topics to enlighten the public, for patients to understand, and those who are suffering signs and symptoms of menopause to know that there is something we can do.
Yeah, Doc, if I have not been as seasoned as I am right now, I myself may have been a little bit uncomfortable having this conversation with you tonight. But, this is what we do. Our job here is to bring the information to the public and to give them in the best way possible. And so a couple of things I want to ask about menopause tonight. And the first one is that menopause, from what my research shows, is that it can be within 7 to 14 years. I hope I'm right. You'll correct me. Between 7 to 14 years, and it can start as early as in the mid-30s.
Absolutely. We would not define
the symptoms.
We wouldn't define menopause. So normally the definition is usually between 40 and 58. Generally. If you have ovarian failure under 40, we call the premature ovarian insufficiency. So if it falls under 40, Robert, if you give me the second slide, I just want or define as there are different symptoms, so we'll go through the different types of symptoms.
Yeah.
But we call them vasomotor symptoms, and there's a change in and there's cessation of menstruation. That is your menopause. So you have symptoms and you stop having your period, and that is menopause. But before that, patients go through a period called perimenopause, where they have alteration in their cycle. So there's an alteration of the cycle and they have symptoms of menopause. But the period is not completely stopped. They're still having either irregular bleeding, prolonged periods without bleed, but they will have a bleed. Now, when you stop having your periods for more than 12 months, we will define that as your menopause. So no period for 12 months with symptoms, menopausal symptoms, which I will go through in a minute. We will say that is your menopause. If you're still having period and you're having symptoms, but your periods are irregular, we will call it perimenopause. And then postmenopause is any time after your menopause. It's postmenopause. Now, menopausal symptoms are very, very common. I mean, lots of time people accept it as a normal thing. And yes, it's normal, but it can cause distressing symptoms for patients. And up to 2/3 of women would have symptoms of menopause generally. But, they don't bring it to the forefront. They don't discuss much about it, and they tolerate it to an extent. And of course, they are lots of time in distress, and we can do a lot for it. So that is why you don't want to go through that. So that is the definition. So I will go through some of the symptoms as I discussed. So if we go through the symptoms, I want to bring the slide up because it allows patients to have a little visual, and I think they remember it for longer, and there's better clarity in that. So I spoke about vasomotor symptoms. So what is that? So you would know that women will come and say, I'm having hot flushes.
Right.
Or so hot flushes really is a feeling of warmth in the upper body. And you can have that many times in a day. Usually, they say they average 8 to 15 times per day. They can last 4 to 5 minutes.
What causes this?
Well, it is, the theory is a change in the thermoregulation. So in your brain, there is a temperature regulation system. And because of the hormonal changes, it causes a change in that equilibrium. And it reset that thermodynamic state.
Okay.
So it is explained by chemical neurotransmitters and hormonal influence. But there is a specific,
So it's not
theory.
just some simple biological thing happening in there.
Well, it's a biological process,
Right.
but it is there's an explanation.
Complex.
It's complex.
Yes.
Because our body has got a thermostat. When you go to the mechanic, they say, hey, this is a thermostat and it regulates
the temperature,
temperature. Likewise, our body has got a thermostat in the brain and it regulates our temperature. So when you feeling cold and you start to shiver, what happens there?
Right.
You're shivering to generate heat.
It's a vibration.
Yeah. And even when you have fever, you'll see the body thermostat goes up. The body is shivering, but you're having a fever, thermostat goes up, the body is shivering to generate heat to match the level that it is risen.
Right.
So there is a complex mechanism in how temperature is regulated in the body. But coming back to your vasomotor symptoms, so these are your hot flushes. And they can be associated with palpitations, sweating, and that is your classical symptom. Now, you have also what we call urogenital symptoms. Now, because of the hormonal changes, our body, estrogen generally, is needed for the cells and for lubrication and for all of that in the vagina.
Yes.
So once you have a low estrogen, it can affect that normal chemistry that goes on there, and also it changes the pH. So the acidity of or alkalinity of the vagina changes during menopause. So what you can have what we call dyspareunia. That is, you have painful intercourse. Because the lining is thin. It causes thinning of the lining of the vagina, so you can have painful intercourse. It can be associated with bleeding. Because of that, lots of women will come in with urinary infection. They will have urinary symptoms. They may have boarding when they pass urine. And as a matter of fact, I've seen a large proportion of patients who would come in with something called recurrent urinary tract infection. When you take a history and you try to dissect exactly what is causing their problem, you find that it is caused by irritation of the vagina, which then leads to infection. So just by controlling that, you prevent the infection. So it's not purely, right, these patients, they would go wrong and have antibiotics on top of antibiotics, but it would still have the recurrent nature of the condition. And once I start treating them, and I will go through the treatment as to their topical treatment and other means of, modes of treatment, once you treat that condition, the symptoms will go away. Now, so you get urogenital symptoms, we call that. And then you have, big in that, you have psychological symptoms.
Yeah, well, those are the ones I wanted to talk to you about.
No, absolutely. And lots of patients will come in with all sorts of conditions, things like confusions, irritability, they're tired, they aches and pains in their muscles, they have fuzzy head, mood swings, and they can't remember, the memory goes. And, they go to doctors and they're trying to, of course, we want to rule out other causes. I'm not going to say to a patient in the menopausal period, once they have these symptoms, I'll just blame it on menopause.
That's right,
We always look for the dangerous things, try to rule that out and say, fine, we can't find anything more worrying, and this may be directly attributed to your menopause state. And of course, there's no harm. I mean, lots of times we do a trial of medication and see how they respond. So that is generally your symptoms. We give the definition and what are the symptoms of menopause.
Right. Going back to the slide that you had there, and you had loss of libido. And this is a big thing, because why I say it's a big thing, men also need to understand how is it that menopause affects their other halves, their wives, their partners, whatever it is, because you need to understand that if this person is going through menopause, she is going to suffer from a loss of libido. She may not, as you rightly said, she may not be able to even lubricate for proper intercourse. And the reason I want you to talk much about this also is because I want men to understand that this is a problem that we need to understand indeed, because it's going to affect the relationship and really and truly, it's a woman has been having her period since she's in her early teens, sometimes she stops having her period. It's like a little break she's going to be having now. Why not support her until she gets to that spot, put to that stage? But
indeed. So I mean, loss of libido is common. And more so, you have loss of libido because of the hormonal influence in the body. But also, even when you attempt to have intercourse, it is painful. And that alone is a turn off for a lot of women. Yeah. So, couple of things. I mean, as you are aware, sexual intercourse, in terms of the pleasure of sexual intercourse, is a combination of factors. It is not only the physical act of intercourse, but it's a combination of the chemistry that goes on in the body. Right. And if you're not in a good psychological state, you cannot invoke the good hormones. If you're in pains, those hormones cannot flow to give you that pleasure. So men, of course, I would always, I try to explain the menopause cycle and the period of menopause for them to understand, and they can reach out, they can discuss that more. And in a relationship, that conversation is important. Yes. So it is not like, okay, the woman say, right, I don't like you, and I don't want to have intercourse with you. It is more about, I'm going through a period that I need a bit of a support. Yes. And of course, there are other forms of pleasures, sexual pleasures that you can have without creating that all that discomfort. And I suppose at some point we will go through some of that. I mean, not to miss that men also go through periods of something similar to menopause that called andropause.
You know what? Somebody just put that question in. I just picked that question up on the from Facebook, and somebody did ask, do men go through menopause or woman pause?
Yeah. So it is when the man hormone also diminish. So women has got estrogen, men has got testosterone. So when you have a drop in that testosterone level, you go through similar symptoms. They get sweating, they get low libido. And of course, there is a fix for that as well. We will discuss that at a different stage. But of course, I'm happy to take questions on that.
Yeah.
But coming back to that libido. Now, when I think I should touch, since that I'm discussing that aspect of it. So if we're looking at low libido and painful intercourse, we can look at how do we manage that. If it is a symptom in isolation. So I said to patients, they get what is called urogenital symptoms, and that is to do with the vagina and urinary system. If you have recurrent infection and you have bruising in the vagina, you would want to try. So what we want to do, we want to give the least medication that is doing the job, and we want to give medications generally, you want to give the ones that would not have a systemic effect in the body if the problem is localized. So if I have a problem down below, I would want to treat that first locally. And only if it is not helping, then I go to give something generally in the body that goes into the whole body. So the local treatment, what we would want to start with. You have your normal vaginal lubricants and moisturizer, but specifically for menopause, we give estrogen gel. So estrogen comes in different form. So that's your replacement now. So we're talking about we're replacing some hormones.
Right.
Your hormones are low, but because your symptoms are confined to the vagina, I would try to treat the vagina symptom on its own so that we don't have that widespread effect on the whole of body. It is deemed very safe. Lots of people in the old days, they didn't have enough evidence to say how long we should use estrogen for in the vagina. So it comes in tablets form. You could put a tablet up the vagina, or you have gels that you can insert into the vagina. And it's very simple to use. And now we are encouraging more and more women if they reported symptoms related to that, we will give them. So it is safe to use on its own. It is safe to use with moisturizer. It is safe to use with all these lubricants. And it is also safe to use with additional HRT.
Right, hormone replacement treatment.
Hormone, which we will come to in terms of the medication, the tablets and other forms of HRT. But so that's a good point to note. And then, of course, once you've fixed that, then of course, if there's a combination, so I normally tell patients, if all those symptoms that I talked about, if you have isolated symptom, you can then use medication just for that isolated symptom. So if you have sweating alone, there are some drugs we can use just for sweating. There's a drug called clonidine. You can use that just for the sweating. But if you have a combination of low libido, hot flushes, urogenital symptoms, then I would want to give you a replacement of your hormone. So let us come to a little bit on the management, if you think that's a good idea.
Yes.
Yeah. So I like to, if Robert, you can just put up the management slide. And what I want to do, as I said earlier, in most of my talks, I would try to encourage lifestyle modification and a non-pharmacologic way of treating any condition for us. I always emphasize on that, because you want to do things that you can do at home or without actually seeing a doctor or actually taking anything, that the body might react to. So if we go to management, we get lifestyle measures. And some of the lifestyle measures that is recommended would be aerobic exercise. So there is a difference with aerobic exercise and weightlifting, for instance. It is shown in studies that aerobic exercise is more helpful than weight exercise for menopause. You want to decrease your alcohol intake. You want to decrease your caffeine intake. So that's about your lifestyle management. How do we help with that? Now, we have some complementary therapies, complementary therapies are alternative therapies. Some patients would say, well, I don't really want to go on tablet, proper pharmaceutical drugs. I want to take something that is natural. And there are a few natural things. Evening primrose, you heard of evening primrose oil. Isoflavones are a set of phytoestrogens, we call it. So they are a set of products that have got estrogen. So we know it's a depletion of estrogen, so we are giving you plant products with estrogen.
Okay.
And that is called isoflavones. And it's contained in soya products, red clover, you've got isoflavones. And there is something called black cohosh. Now, all these things, I mean, I recommend them because studies have shown that they can alleviate symptoms. But what we don't have robust data on, we don't have robust data on the dosage, for how long, how it interacts with other drugs. So in a medical standpoint, I mean, it's been around for a while. Patients use it and they're having relief. And I would recommend it in the first instance. But I would say just be cautious. Maybe if you go to the health food shop, they would have more data on, how to use it, what's the dosage, because they sell that, and they would the manufacturer will tell them, hey, this is a number of tablets you have to take per day and how it works. But I just a warning that sometimes you can have interaction with your regular medication, so you just gotta, look at that a little bit. Now, importantly, psychological therapy is also important. I know you're big on psychology and all the psychological methods, but psychotherapy, there is something called cognitive behavioral therapy. It is accepted that that's a big way it can help in a big way it can help patients. So we have psychological support. I would normally send patients for that as well, because also it is a distressing period in a woman's life. It can affect relationship. It can affect so many things. So
confidence is one of the things that goes down. And with confidence goes down so many other things.
Sure, absolutely.
Yeah.
And then of course, Robert, that's okay. I'll just go through the others. Then, of course, as I said, for symptom management, you can then have specific drug that we tend to use for symptoms. And these are, if patients don't want hormonal therapy. So the big deal in menopause is a HRT, which we call hormone replacement therapy. Yeah. And of course, there are some pros and cons of hormone replacement therapy, which I'll go through. But some patients would say, right, is there an alternative to hormone replacement therapy for the management of my symptoms? And I would say yes. There are some drugs that work on the chemical in our body, so they're not hormones. So they work on the neurotransmitters, they work on the brain chemistry. You have drugs, antidepressant drugs, they're called SSRI. You have a drug called pregabalin. These are drugs usually we use for pain management, gabapentin. But in menopause, it works for those hot flushes and all those bits. And then the last and final, if nothing else is working and patients are saying, fine, let's go for HRT, then I said, fine, let's take HRT. Now, in the old days, HRT has been, talked about a lot and people were scared about taking it, but the evidence is now overwhelming as to the risk-benefit of HRT. We understand a lot more on HRT. There are loads of guidelines in it, and I would go through HRT. If you want to take some questions in between.
Well, let me I'll tell you what we have here. Go ahead, Doc. I'll get these questions again.
Right. So HRT, hormone replacement therapy.
Okay. So before you go on, we're going on HRT. Right? This is the question I want to do with. Doc, HRT can cause cancer. As I read, cancer feeds on high estrogen. So as you're going through this, see if you can you'll deal with this question.
On HRT, of course, I will come to that.
Yeah.
So I think what we should do is to talk about HRT risk benefit, and then of course we could say, so let us go to risk benefit. One second, let me see if I get a slide on that. Where's that slide? Risk benefit. No. Okay, fine. All right, we'll talk. Of course, let's look at the benefits of HRT. HRT alleviates symptoms, so that's the big deal that, of course, you're getting all these confusion and lethargy and mood swings and low libido and genital symptoms, hot flushes. That's your HRT, and it works in most patients, and that's your benefit. It has got some other additional benefits. It helps bone density. So there are patients, as you get older and you lose your hormones, you get weakened bone. There's a condition called osteoporosis. So HRT strengthens the bone. There is some evidence in the younger patients. You have benefit in cardiovascular benefit in young patients. Of course, as you get older, your risk of any about six. So when we look at patients age 50 to 69, and with no HRT use, you have 63 per 1,000 normal breast cancer. That's without HRT use. If you use this, so there are different types of HRT. So I'll come to that, in due course. But if you use estrogen only HRT, you have 5 extra cases. If you use sequential, so HRT can be where you give it cyclical. So HRT can be, the regime is there are 2 types of hormone. So if you give estrogen alone, and I'll tell you when you use that, you get 5 extra cases. If you use a sequential weight chain, you use, some days you use 1 hormone, and some days you use 2 hormones. You get 14 extra cases. And when you use both hormones every day, you get 20 extra cases. But let us put that in context. Robert, there's another slide there with some, it's called Understanding the Risk of Breast Cancer. Right, lovely. I know this slide is a little bit, I'm not sure if,
can you zoom in on it from the top, Robert, and we can...
If everyone can see it very clearly.
And then we're going to move it down. Scroll long, yeah.
Yeah, but when I say that you have, 5 extra cases with estrogen, or you have about 14 extra cases with your sequential therapy, let us talk about,
it's better now.
Yeah, in patients age, so this was done by the Women Health Concern, they put this out, and they say just for patients to put breast cancer in context. These are patients between 50 and 59 years of age per 1,000 patient. And if you, for instance, you take HRT, you have about 4 extra cases. In our first case slide that I showed, these are patients between 50 and 69. This is between 50 and 59, and they have 4 extra cases, right? That would combine HRT. And when you look at, I just want to put this in patients who smoke, for instance. In patients who smoke, you have 3 additional cases.
Wow.
So if you're talking about, I am smoking between the age of 50 and 59, just by smoking, I have 3 additional cases. And by taking HRT, I have 4 additional cases. It's really probably equal. So if I were to tell you, stop smoking, is equal to me to tell you, HRT give you that risk as if you're smoking, not the risk of lung cancer. I'm talking about breast cancer here. And when you look at patients who, for instance, have alcohol, an additional 5 cases in women who drink 2 or more units of alcohol per day. So it is not anything scary to say that breast cancer, you will get breast cancer by taking HRT. It has got its place. And of course, if you have lots of symptoms, lots of drugs have got side effects, and of course we monitor those side effects. But when patients come to me and having symptoms and we discuss an HRT, I will go through those risk benefit with them. It strengthens your bone. So yes, it plays. But when we look at the benefit generally, so I would give this ballpark just to explain to patients in general terms. I say the evidence is very clear now. If you're under 50, the benefit far outweighs the risk. If you're under 50.
Yes.
So if you're under 50 years of age, you're getting lots of hot flushes, you're getting lots of menopausal symptoms, I would say to you, benefit outweighs the risk, by far have it. If you're between 50 and 60, again, so I said if you're under 50, it far outweighs the risk.
Right.
If you're between 50 and 60, it outweighs the risk. If you're between 60 and 70, it's probably equal.
So, yeah.
And if you're over 70, the risk outweighs the benefit.
Right.
So if I were to prescribe it, I would say to patient, I'll prescribe it up to 60 years of age. And then some patients they don't need it for that long. Because sometimes you may need HRT for just a few years. Because once you start, your symptoms are getting better. Then after a few years, we tend to start wean you off and see how you're progressing. And then, of course, the intention is to stop it. So, generally speaking, the benefits, outweigh the risk in those, in those age groups.
Right.
Now, if I go down quickly there are some cautions and contraindications to HRT. Some patients who I wouldn't give HRT to. And these are patients who have had breast cancer. Not to say that there's a total contraindication, like the estrogen vaginally can still be used if you have breast cancer. So it's not a total contraindication that you can't have any form of HRT if you have breast cancer. It is still being used. If you've had a previous stroke or a heart attack, I wouldn't give it to you. If you have liver failure, I wouldn't give it to you. And of course, in patients with uncontrolled hypertension, and if you have vaginal bleed that I can't explain, I would say, let's find the cause before we treat. Now, let us go through the different types of HRT and when do we prescribe it? And then, of course, we can take some questions.
Right. So, a lot of people are saying here, I'm reading it online, they're saying it's very, very interesting discussion tonight. And I'm happy that, we have this sort of response.
Yeah. So can you bring the slide with the types of HRT? Robert?
This one here?
Yeah. All right. So when we talk about HRT, as we know, HRT, there's estrogen only, and there's estrogen and progesterone. So we have a depletion of estrogen. That's what happened in our body. And we can take estrogen on its own, but if we take estrogen on its own, it can increase our risk of thickening of the lining of the womb and endometrial cancer. So what we do, we give a protective progesterone, protects the lining of the womb. So the combined one is called estrogen and progesterone. So patients who don't have a uterus, we just give them estrogen only. If you have a uterus, there's a question here on if they have had a hysterectomy.
Right. There are quite a few questions that I've captured so far about hysterectomy because...
Yeah, if you've got...
I'll tell you, one person said, I know someone... so this person, I have 3 aunts that had hysterectomy and two had flushes and the other nothing had nothing after she changed her diet. But it seems as if people are saying here, another person is, I know someone who had partial hysterectomy. She suffers from the hot flushes and the work. And the other person that had a total hysterectomy, oh Lord, it's not good at all. One time we feared her life and sanity, but she's better now.
Yeah. Yeah, I mean, if you have a hysterectomy, it depends. Lots of people who undergo hysterectomy, depending on the reason you're undergoing it, you can have a hysterectomy plus and minus oophorectomy, we call it. That's where they remove your ovaries. So if you have a hysterectomy orally and they take away your ovaries as well, you should have hormone replacement therapy. As a matter of fact, there's so much a downside to stopping to have premature menopause. So if I were to take away someone's ovaries, then I'm inducing premature at an early age. Let's say under the age of 40, I take away your ovaries for other reasons. You've got, something like cancer of the ovaries, you have to remove it, or you have cystic ovaries, or bleeding, or torsion, or whatever. You would have to have HRT, hormone replacement therapy. So there's a place, because if you don't and you take it early, then you have all the consequences, increase the risk of heart attack, you have weakened bones, you have, early menopause, really.
Yeah.
Now, I was going back. So, okay, we understand the types of HRT. We have the combined, and then we have the single. Estrogen is only used if you don't have a uterus. If you have a uterus, then you use the combined estrogen and progesterone. Now, just for simplicity, the regime is you can have, when you take the combined drug, the regime could be either you take the combined continuously, so that is in a pill or with a patch or whatever, you're taking it by what form you can have it. You take a fixed dose of the 2 drugs. So a fixed dose of estrogen and progesterone. So that is called continuous HRT. or you can have 2 weeks of the month, or minimum 12 days. You can have the combine, that is estrogen and progesterone, and for 2 weeks you just have estrogen.
Okay.
And so we will tend to give that in patients who are perimenopausal. So patients who, as I said, your period, you're still having some period, but you're having symptoms. So if you're having period and you're still period, but it's coming infrequently. So once every 2, 3, 4 months, you're having some period. Then I would choose we call it sequential or cyclical HRT, where you give different combination of the drugs. But if you've had a period for over 12 months or you're over 54 years of age, I'll go straight for continuous combined HRT.
On that same thing, somebody just sent a message and said, "What are the different reasons for bleeding at post-menopause?"
So that is a very serious condition that always, not necessarily, let me rephrase that. That's a red flag sign that all doctor will investigate if you have something called post-menopausal bleeding. So once you stop having your period, 12 months have gone, I haven't had a period for 12 months, and now you start having bleeding. The first thing you have to exclude is cancer of the womb. Mm-hmm. Every doctor, everyone on the planet who deals with, anybody with postmenopausal bleeding, that's the first thing we have to exclude, that you don't have cancer of the womb. Once we have excluded that, then of course there are other reasons. You could have something called a polyp, something very, very innocent. You can have conditions of the cervix itself that can cause it. You can have a urinary tract infection. So you can have, we talk about bruising of the vagina. Mm-hmm. Just by bruising of the vagina, you have bleeding. But we cannot, our job is to rule out the most important thing and exclude it. And of course, you'd want to exclude that.
Okay. One more other thing here. Doc, are probiotics safe to use during menopause?
Definitely. Probiotic. The whole theory nowadays on probiotic and the gut microbe. So our gut has got lots of microorganisms, bacteria in it, and it controls our immune system. It can control our mood. It can control our hormones. It gets so much now. There's a big study being done on the gut microbe, and probiotics tend to rebalance that, or tend to give you gut microbiome that are good for the bowel. So yes, I would recommend. I'd say there's no harm in doing that.
Okay, all right. So but continue with where you are.
Discussion. So I wanted to just talk quickly because this is a new thing. The up and coming, the new evidence and the new data we have got. So lots of people used to talk in the old days. There are a couple of studies on the WHI studies and the Health Initiative study, the Women Health Initiative study. They looked. In the old days, they were worried about stroke and heart attack with HRT. The risk of blood clots and all of that, they were big on that. Mm-hmm. Now, those studies, when they reanalyzed the studies, they were looking at women in the older age group. So now, with the newer forms of HRT and HRT being recommended in the younger age group, in terms of, when I say the risks far outweigh the benefit on the 50 to 60, the benefit outweigh the risk, you'd see that the type of hormone is important. So it is recommended that you need two hormones, estrogen and progesterone, in combined preparation. That is for majority of patients if you've got a uterus. But the best form of estrogen would be in patients who have got, high risk of heart disease or diabetes or high blood pressure. I would prefer to give them the gel form, the topical estrogen.
Okay.
So when you take in these hormones now, they come in different preparation. So you can take a tablet. A combination of the tablet where it's got both hormones, estrogen and progesterone. You can have it in the form of a gel or a patch. So the patch absorbs through the skin and it gets into the bloodstream and that. And then you can have it intravaginally or in the uterus. You have the Mirena coil, for instance, has got the progesterone component of it that you can have in the uterus. So depending, your doctor will discuss in different countries, they have different preparations and different regime. So when we assess in a patient, we look at their, so we individualize care. That's the operative word. I mean, there's no one, you know, they're different for different patients. We look at their history, the comorbidity, and we individualize care. It's not one size fits all, you know? Yeah, so I think that's in summary. I mean, I think let's take some questions before.
Yeah, well,
time is up.
we're open for calls also. You can call. Those are numbers in the screen. You can call us. Suddenly we got some time more to go. Doc, so there is this other question here that says, at what age do you start premenstrual?
So there isn't an age as that you could say it defined as premenstrual. So premenstrual, so we say it can happen from the age of 40 because under 40, and if we show that you are having menopausal symptoms under 40, I would want to know if you're having premature failure of your ovaries. So let's say from 40, you're having, so the definition of perimenopause. So sorry, the question is premenstrual.
Right.
It's a different question. I'll just clarify that. Let me take this. Hello?
Hello, good night.
Hi, good night.
Yeah, good night. I'm watching your show.
Yes.
I was watching your show and I got a question. By the way, my name is Capo. And
Yeah.
I'm trying to ask you something. Well, lately, I don't know if you have to help with this. I went and I sleep against you, and for some reason, I get a lump on my balls. I go to the hospital and they say they don't know. I don't know what to say, and it's very concerning me now. I had a person like with tight buckle.
Yes.
So like it's affecting my balls, so I don't know what to do.
All right. I wouldn't mention your name because this is, of course, confidential. You have said it already on air, nevertheless. So your question is: you slept with a girl, a woman, and then you notice a lump on your testicle. Now, two things: the lump on the testicle could be related or unrelated to sleeping with somebody. It's a difficult one unless we understand a little bit more about lump. So I'm gonna ask you, the lump that you find there, that you found on your balls, is it an ulcer with a lump or is it just a little cyst? How would you describe it? Is it a pea size? Is it hard? Is it soft? Describe it for me.
It looks like a marble, you know, like them big marbles, like about that size.
Yeah.
And 1-2 times it will get hard, and then like in the night it will get soft. I don't know.
And do you think it is just under the skin, or do you think it's in the testicle itself? So if you examine your testicles, you'll see you have the skin, and in the bag itself you have what we call the testes. That's where the testicle is. Now, do you think this lump is part of that, or is it just under the skin where it is separated from that and it's on the outside? What would you say?
It's on the outside.
Yeah, because what you're describing, I think, is just a simple cyst. Is just like a cyst, a hair follicle cyst, or a gland cyst on the skin of the scrotum. I think that's what you're describing. In my opinion, it's just a simple skin cyst. It's got nothing to do with the fact that you slept with a woman. It is more, is a skin condition, a cyst form under your skin. You've got glands there. You've got hair follicle. You've got, and they can form cyst. The conditions that you would have if you think that it is sexually transmitted condition, you can have something called...
Somebody been telling me that I might get cut off my balls, so you just want to know if
I think that's the biggest concern right now.
No. I can assure you, I don't think we need to cut it out unless it's something dangerous like cancer of your testicle, which is nothing to do with that as well. It is something different. But I would advise. So if it was due to sexual intercourse from an infection you've picked up, the type of infection we're concerned about are warts. So you can get like a fleshy something growing on the scrotum, or around the genital area, and you can get that as a form of sexually transmitted condition. The other conditions would be things like herpes, where you have ulcerations, and all the others you would have like gonorrhea, and those bits you tend to have discharge from the penis. So I think what you're describing has got nothing to do with having intercourse with someone. It's probably something that was there and you only have noticed it afterwards. I would advise you to see a doctor, examine your testicle to see if it's coming from the skin or if it's coming from internal. If it is coming from inside of the testicle, then you would have to have an ultrasound scan just to see if it is anything more worrying. Usually, if we feel our testicle, you sometimes feel a lump, and I would advise patients when they feel it, they try to establish if the lump is inside of the testicle itself or it's on the side. Because you have something called an epididymal cyst. You can have an innocent cyst on the side of the testicle that is not dangerous and is just we call it epididymal cyst, does no harm. But if we find that this lump is originating in the testicle itself, then that warrants investigation.
Okay, I'm gonna check a doctor. Come here more than next time, put oil in a spoon and burn it, but thanks, don't check a doctor.
I would not recommend you try to burn it in any way or form, because you can cause more harm than good. So what I would recommend, first of all, see a doctor, get it examined properly, and they can reassure you if it's on the skin and there's a cyst. I mean, we all have cysts, like how you have, if you feel on your head sometimes, in your scalp, you have these lumps.
Little lumps, yeah.
You can get it in the testicle, something similar. Mm-hmm. In the scrotum, that's, in the skin of the testicle. Okay, you take care, and thanks for calling.
Yeah.
All right, cheerio. Bye. Right, so that's, I just want to address, I was addressing that question, pre-menstrual.
Yes.
And I was discussing perimenopause. So,
right.
sorry. So there was
do you start premenstrual?
So premenstrual mean before menstruation. So there's two different conditions.
Right.
Sorry, because we were talking menopause, I thought it was perimenopause.
No.
So this is premenstrual.
Yeah.
So what premenstrual means is before the menstruation. So once you have menstruation and you have symptoms before menstruation, so you have before your cycle comes on, we call it premenstrual symptoms.
Let me
and it varies.
Let's take this call. Good evening, caller. You're live on air.
Hi, good evening, guys. If you hear a little bit of host, because I'm having a little bit of a cough and flu.
Perhaps Doc can recommend something for you too.
Yes, of course. Go ahead.
Yeah,
sorry,
go ahead,
I'll recommend after your question.
No,
Unless it's related to that.
Cash would have featured me actually in one of the programs in connection with the breast thing with my daughter. I would have lost my daughter.
Oh yes, I recognize you on previous calls. Yeah, indeed.
And,
thank you for calling.
We're doing to see if we can curb it. However,
We're losing you.
You're breaking up a bit. I don't know if it's your reception or ours, but go ahead.
I don't know.
You got to speak, Len. I'll tell you.
We're not hearing the question. Sorry. Go ahead. Keep talking. I'll try to figure it out.
Let me call. We'll have to call. You'll have to call back because it's not coming through properly. Yeah.
But let me quickly, somebody say, hey, caller sounds very stuffy, which is true.
Yeah.
So generally speaking, if you're a healthy person, and I just want to address this in 5 seconds.
Yes.
Lots of people get cough, cold, runny nose, congestion, and all of that. If you've got fever, cough, cold, runny nose, you're congested in the head, but you don't have any difficulty breathing, as in lung condition, your temperature is controlled by normal paracetamol, you don't have any shortness of breath, you're not bringing up blood when you cough, and it's a common cold kind of symptom, you don't really need antibiotics. What I tend to tell patients in the first week, your symptoms may get worse within a week, within the first week. But if in the second week you see that you're better today than yesterday, and you're progressively going up, I would say to you, let your body handle it on its own. There's no need for antibiotics. Just use over-the-counter medication. That's your cough medicine and your painkillers and lots of fruits, lots of vegetable, and rest. I mean, not to say if you have underlying conditions, you've got known lung conditions, COPD, asthma, heart disease, diabetes, then you ensure you see a doctor if you're worried.
And then a lot of people, like this gentleman is calling. He's calling from New York specifically, and because they're going out of autumn into winter, there's a seasonal change, and then you get the seasonal flus.
Absolutely. So you get, usually the majority of cases are viral infections, and there's no antibiotic that we can use for viruses. Generally, virus takes it, your body is self-limiting, so the body has a way of getting rid of it on its own, and it is just more supportive. So the supportive would be your cough medicine and your, lozenges for the throat and your painkillers. Yeah. And of course, lots of rest, lots of fluids, and fruits and veg. Yeah. He's calling again.
Oh yeah, it's all right. Let's see.
If it's,
I hope the connection is better now, Mr. Ramjiwan.
I hope so. My question is that because I think I complained to Akash about my cough and the bronchitis.
Yes, bronchitis. Yeah.
Just that comes up every morning and afternoon. Well, morning more, and with a stuffy nose and whatever. And I've been trying the so-called local treatment, meaning the lime juice and the black pepper.
Yeah.
I have not received official medical. And Akash, I speak to you every day.
Yeah.
But I kind of find today it's juiced a little bit, but from the professional. Situation like this lasting for over a month. Are you antibiotics in situations like
yes, I would say there is evidence. It could be just your sinus. You've got a type of sinusitis, and evidence tells us that if you have prolonged symptoms, antibiotics would shorten the course of your symptoms. So we have enough evidence to tell us that. However, not to say that it wouldn't go away if you don't take antibiotics, but I would think that if you have cold for about a month, as you're saying, and you're having, green, yellow phlegm, more than likely this sounded as if it's coming more from your sinuses than your chest. You can have a bit of bronchitis with it. So, when people say they have head cold, that's a kind of sinus issue. So in your head, around your face, you've got sinus pockets there.
Sinus
cavities, and that's where what they describe as head cold. Yeah. Now, you can have it from the bronchus, that's your big airway, and of course you would cough and you'd have those, phlegm coming up from the chest. I would say a month history would probably warrant some antibiotics depending on your findings. The other thing I would want probably is if you're having wheezing or you're having any other condition of the chest, we would want to see if you have a condition called COPD. I don't know if you were a smoker. Were you a smoker in the past?
Smoking.
We lost you there. Smoke, yes or no?
Since 1993, I have not put a cigarette in my mouth.
Oh, okay. So you're an ex-smoker. Still, there are other patients who can have lung conditions, bronchiectasis, and, where you have infection in the lung and your airway is a little bit that thing. I mean, I would still advise anyone with a cough or any symptom that goes on for more than a month warrants investigation, or at least you should see the doctor to do some initial.
Honest with you, I'm one of the hardest guys.
You gotta get injection. When you get hard disease, gotta get injection. All right. Thanks for coming through, though.
All right. Take care. Thank you.
Yeah. So I have this question here. Should we increase our calcium? And then somebody answers and said, I think so.
Yes.
I do. Osteoporosis makes our bone very brittle during menopause. So this person's actions should
So
lead to
actually,
callus.
that's the answer there.
Yeah, yeah.
Indeed, because in postmenopausally, you have weaker bones, so we would want to increase our calcium. And patients who are abroad in Guyana, thankfully, we get lots of sunshine. We also recommend vitamin D supplements.
Right.
So that's a good one.
Yeah. So next one is, Doc, can your thyroid be affected during menopause?
Thyroid generally, not that I would say directly because of menopause. But as you get older, you can have your thyroid hypoactive thyroid, or I go either way. But your thyroid can get a bit sluggish. But I wouldn't say that directly the menopause is the cause of it.
Okay. Right. So we got a few minutes more. Just send in your questions or call, and we're gonna take a few more questions. But
I want to address. Okay, go ahead. Tell me.
No, I was going to say continue in the meantime.
I was going to say, lots of people talk about tests for menopause. So I just want to quickly address that. So if you have there's a test, there's a blood test for menopause. It's called a FSH, follicle stimulating hormone. So what tends to happen if you have, it creates a negative feedback. So your body not producing a hormone, it causes your body to produce an extra of another hormone called FSH. So if your FSH is high, so when your estrogen low, it stimulates your body to produce another hormone to ask the ovaries to work. So you have that feedback cycle, right? So there's a test that we do called your FSH test. And if it's higher than what it should be, and there's a cutoff limit, depending on the lab and the units that they're using, it will tell us that this is likely menopause. But by most patients who have got classical symptoms and they don't have the period, there's no need to test them. We usually test patients if we are unsure, or if they're having premature ovarian failure. They are between that age group where they're having periods but not quite, and they're having some symptoms, and we want to, could this be as a result of something else? So we would, test them. But generally, yeah. So patients would come and ask for a test, and of course, there's no harm in testing. It does no harm. You can test them. But if you're on the pill, contraceptive pill, combined pill, you can't. The test is not reliable.
Okay.
You'll have to stop the pill. I mean, there's another thing with HRT. HRT is not contraception. So if you take HRT, you still would have to be in contraceptive pill. You could still get pregnant during that perimenopausal state. So there are contraceptive options that we will discuss as well with HRT. Generally, you can have the HRT with the progesterone type of contraception. And contraception would be another topic I will talk on as a big topic, because there are different forms of contraception, and we can talk about emergency, long-term contraception, and the different types of hormones.
Bottom line, should someone who's experiencing symptoms of menopause, should they immediately seek to see a doctor, and should they also be, if they're having mood swings and so on, would you recommend that they see someone probably who can deal with the psychological issues also that they're going through? And is it because should they go see a doctor so they can understand exactly what's happening in their bodies and how to deal with this?
I would definitely say so. I wouldn't think that, when you have all these symptoms that we talked about, there are so many other medical conditions that can cause it. So what we want to do, ensure that they're not due to other causes. So yes, you should see a doctor. And then if it is menopausal related and it is distressing enough, then we would say, fine, you can do some alternative medication in the beginning. And if you're not better, then we go straight for HRT. And as I say, if you're in that age group where the benefit outweigh the risk, don't hesitate, go for it. And that's my general recommendation. I'm a pro-HRT doctor. There are lots of, sometimes some doctors are not pro-HRT. I don't think women should suffer in silence. And I think that there's so much of medication out there and different regime. And looking at your risk-benefit, we can individualize treatment. And patients can have a more fulfilled and, happy life.
Well, I can tell you this, that because I know we're going to do this, I was checking a lot of stuff on the internet, and most of the things, I haven't seen anything against HRT really. but most of the little things I was listening to were, we're talking good about HRT. So, Doc, we run out of time. We've had some. Let me see, to all of the life, Doc. How early can a woman start menopause? So we can take this last question. How early can menopause start?
So we say up to age 40. We would define menopause can be as early as 40, as late as 58.
Okay.
40 years of age, as late as 58, yeah.
All right, great. So
but you can have premature menopause, where we call like ovarian failure, at any age.
Right.
If your ovaries are damaged,
yes,
it induces a menopause.
Exactly. That's because.
So, but that is not defined as menopause. That menopause is when it happens naturally.
Yeah, right. Because menopause is basically the
a natural process in the body.
Dysfunctioning of the ovaries at a particular time.
Yeah.
Right. So, Doc, again, it was an interesting topic tonight. Hopefully, we bring another interesting topic next week. I know there are some burning ones out there. Some people were asking about ED. Erectile dysfunction is something we're going to have to touch on.
Yeah, andropause.
Right.
So the male version of menopause is andropause. So we can talk about that, and we can talk about erectile dysfunction.
Yeah, because as you rightly said, some of these things might be considered taboo, but then again, we have to bring it to the table to discuss it. So again, Doc, thanks so much. It was a real pleasure tonight.
For having me.
Thanks for everybody that was interacting with us and sending your questions. To the young man that to the man that called. I hope to the two gentlemen that called actually.
Yeah.
I hope that both of you would have had some good insights as to what's happening, and that you can get some treatment too. So thank you to the viewers for joining us tonight. A little wet on the road, so just be extra careful when you're driving. It seems that the rains are back. So just be a little bit more careful. I'm always advocating for safe driving. We have too many accidents happening in this country. And now you have to just be careful with the fires too, all right? So thank you so much for joining us tonight. Remember to stay healthy and have a good night.
Thank you. Good night.